Thank you, ma'am, and thank you, Dr. Tony's team for having me here, and especially Dr. Mini. Thank you so much. And so, going straight to the topic, PDR treatment options, weighing the risk and benefits. So, as we all know, it is a microvascular complication which leads to vascular occlusion, and the basic thing is a retinal hypoxia. And this hypoxia is the thing which causes these secondary complications or whatever the decreased vision and whatever we talk about. So this leads to an increase in the VEGF levels. This leads to the clinical features of PDR, what we see like neovascularization elsewhere, neovascularization of the disc associated with pre-retinal or vitreous hemorrhage. Based on this, PDR has been classified into early PDR, high-risk PDR, and advanced PDR. So as discussed extensively, exhaustively earlier, the primary thing is the primary prevention with good lifestyle modification, glycemic control, or systemic factors, and regular screening, especially if you know that you are at high risk of developing diabetes and if you already are diabetic. And the timely treatment by picking up this disease where you can treat so that you can prevent the complications to PDR and also to some extent halt or slow the disease progression. So the basic thing is, as we know, it's a progressive disease with a progressive retinal ischemia. So what we need to treat is this ischemic retina and the sequelae of this ischemia, that is hypoxia, and the factors which causes these complications. So the aim of treatment is to reduce the VEGF level which occur because of the reduction in, because of the hypoxia, and increase the oxygen supply to the retina of the whatever the healthy retina which is remaining, and if it has gone to complications, to treat the complications. So what are the treatment options we have to tackle these things? One is pan-retinal photocoagulation, which is the gold standard, and anti-VEGF treatment. Basically in PDR, it's bevacizumab, ranibizumab, and aflibercept, which is approved. And especially if the PDR is combined with the diabetic macular edema, definitely anti-VEGF has a definite role. And pars plana vitrectomy, when it comes to complications of PDR like vitreous hemorrhage, TRD, combined retinal detachment, neovascular glaucoma. So as already mentioned, like pan-retinal photocoagulation is the gold standard in the treatment of PDR, and it has been proven by the DRS study that those patients who have undergone PRP, especially in PDR and high-risk PDR, it reduces severe vision loss in more than 50% of the patients. So it is a proven treatment. So coming to one case, so here you can see this fundus where evidently you can see some neovascularization here, and the BCVA in this right eye is counting finger 3 meter and left eye is 6.6. And here you can see NVE, there are hard exudates, hemorrhages, and the left eye you can see can't make out much of any neovascularization as of now, but you can see that there are cotton wool patches, so looking at it's more of ischemic. So in these cases where you can't actually really explain the cause of decrease in vision, then we come to the role of investigations to get an FFA, basically to see what is the extent of ischemia and if we can account for the counting finger 3 meter in the right eye, and OCT to look at the type of macular edema. So FAZ, in the FFA you can see that the FAZ is enlarged and it is irregular, and you can also see these extensive capillary non-perfusion areas in the right eye. Left eye again, which was missed in the fundus fluorescent angiogram, you can see this NVD and extensive CNP area. So here you can see almost these capillary non-perfusion areas encroaching to the macula. This gives us a clue that sometimes despite your treatment in future, the patient can still lose the vision of 6/9 in the left eye, because this can prognosticate. This FFA actually helps. Even you can do OCTA nowadays to pick up these findings. And when you do the OCT in the right eye, you can see that there is a cystoid edema here, and this cystoid edema has got this hyper-reflective lining, which is called a pearl necklace sign, which is like a precursor of developing a hard exudate. So suppose this is in the subfoveal area. When you treat this, this might eventually become a hard exudate deposit at the subfoveal and cause a decrease in vision. Anyway, this patient has got a foveal avascular zone enlargement. So what is the option of treatment in this patient? So the right eye, you can see that there is macular ischemia, macular edema, there is a PDR. So first option could be an anti-VEGF injection, because it can tackle both the things of macular edema. Even though it is ischemic, you can still give a try. And left eye, because the macula, there is no edema, but there are some drill changes in the left eye. So the left eye can be treated with pan-retinal photocoagulation. So the option was given for the patient. Patient was not willing for anti-VEGF injection. So the patient was treated with PRP in both eyes. So on follow-up, what you could see that there was some development of the pre-retinal hemorrhage. The hard exudates was still there, vision was status quo, and the patient was advised anti-VEGF in the right eye, patient was lost to follow-up. So this is the importance, like had the patient taken an anti-VEGF injection and gone off, and then the patient would have come with a TRD later. But at least now you are at peace that at least for some time the PRP will take care of this patient. So this is a scenario in our settings actually. So the case 2, you can see that both eyes there is a PDR with the pre-retinal hemorrhage, and the patient underwent PRP in this both the eyes. Here with time you can see that the pre-retinal hemorrhage is slowly resolving. Here it has become a breakthrough inferior vitreous hemorrhage. On follow-up with just panretinal photocoagulation, you can see that the PDR is remain stable with except for that old inferior breakthrough vitreous hemorrhage which is there. So PRP has taken care of this eye alone, PRP alone over the time. So what we learned from this is that FFA is indicated in these cases when before you plan for a PRP, at least in certain cases like this, to know the extent of the capillary non-perfusion, whether it is threatening the macula, to know whether the vision loss is because of the macular ischemia, and also in scenarios where there is a mild media haze because of cataract or vitreous hemorrhage, PRP is still the standard of care, and anti-VEGF may be considered when there is an associated diabetic macular edema. And this is another case where you can see the patient had 636 vision. Patient already had received PRP in both eyes, presented with further decrease in vision in the right eye, and you can see that there is vitreous hemorrhage, there is traction, and temporal there is a florid neovascularization in the right eye. Left eye also there is a pre-retinal hemorrhage. OCT actually helped to pick up the vitreomacular traction in the right eye, and left eye also it is there, but the traction is not that much. Patient underwent vitrectomy in the right eye, and you can see that the vision, but it's only counting finger 2 meter. Probably the macular ischemia is progressing, and in the left eye again the vision has dropped from 6/9 to 2/60 at this point of time. So the second eye was advised anti-VEGF injection followed by the surgery. And with anti-VEGF injection, you can see there was resolution of the vitreous hemorrhage in the left eye, but an OCT showed that the macular traction was increasing and the patient was developing a lamellar macular hole. So, and the right eye, it has developed a macular hole at this point of time. So it is important actually, like serial documentation by OCT and fundus documentation to monitor the progression of the traction. And anti-VEGF in cases of PDR with traction, always keep in mind to keep a close watch and also prepare the patient in case if there is any worsening to plan for a surgery. And so OCT actually in PDR helps in many cases to pick up associated macular changes like macular edema, maculoschisis, macular hole, sometimes vitreomacular traction, and also when we plan for the surgery, especially in those cases with maculoschisis and all, to assess the plane of dissection, it is easy if you have a thorough evaluation of the pre-op OCT. And so now we have used anti-VEGF in these cases. So is it only panretinal photocoagulation or does anti-VEGF has a role? So many studies have looked at the role of anti-VEGF, not in diabetic macular edema, but in PDR also. So this is first one was protocol S, which first showed that PDR can be treated with anti-VEGF injection, and now Clarity study has looked at role of aflibercept, and then combined studies, use of PRP plus anti-VEGF in PRIDE Proteus studies. So what does the protocol S looked at? Whether PRP or anti-VEGF, that is ranibizumab, whether it is worth. So anti-VEGF, the study has shown that anti-VEGF was non-inferior to PRP in treating PDR, and BCA improvement was there, and there was reduction in the diabetic retinopathy grade also. And especially when there is a associated DME, it actually recommends that because it is cost effective. And Clarity again looked at the comparison between aflibercept and PRP, and it was shown that aflibercept is superior to PRP in improving BCVA, but non-inferior to PRP in regression of NV. Then why don't we use anti-VEGF in all these cases of PDR? So this follow-up study have shown that when we looked at the area of neovascularization beyond the 1 year period, it has shown that the patients who were treated with combination or ranibizumab, had an worsening or an increase in the area of neovascularization, and even in those eyes who had received PRP also had a worsening of progression of neovascularization beyond 1.5 years. So this shows that if you don't get a patient for a regular follow-up, the PDR can worsen in these eyes. So that is very important actually when we treat these PDR patients with PRP anti-VEGF alone. And coming to the cases of PDR with vitreous hemorrhage, why don't we treat it with anti-VEGF and not vitrectomy? So this is one case where both eyes have presented with vitreous hemorrhage, and because it was both eyes and patient was given an option of vitrectomy in one eye, patient was not willing for surgery, so was given anti-VEGF in both eyes, even though there was some area of traction component here, and on follow-up we could add PRP in these patients. So there is an option that you can treat these patients with anti-VEGF, but you have to keep in mind that this patient has to be under your follow-up, and the view clears you have to add with PRP. So the protocol AB has looked at the role of early vitrectomy versus aflibercept in patients with PDR and vitreous hemorrhage. So what they have shown is that PPV actually provides a faster resolution or restoration of the vision and resolution of the vitreous hemorrhage. But secondary analysis of these subgroup has shown that early vitrectomy, especially in those eyes with worse vision of 20/800 or with severe vitreous hemorrhage, can benefit from an early vitrectomy. And there is a risk of this worsening of TRD following anti-VEGF injection. So the study has looked at what is the risk of worsening, and it has shown that there is not much of a risk, but still you have to keep in mind that some of them can worsen. So as I mentioned, the patient should be counseled before you treat them with anti-VEGF injection. So why are we concerned about giving anti-VEGF in PDR patients? This is when the patient is lost to follow-up. You have seen that those patients who were treated with anti-VEGF, when they are lost to follow-up, they come with a worse anatomic and functional outcome. So this is if those patients who had received PRP, even they have come back with a decrease in vision or loss to follow-up, even with the surgery, the visual outcomes are better in those eyes who were treated earlier with PRP than those with anti-VEGF injections. So when selecting a patient for anti-VEGF injection with PDR, the considerations are you can use it pre-operatively if there is an associated anterior segment neovascularization, associated DME, or you can use it as an adjunct to PRP. So these were cases where the anti-VEGF was used as adjunct to surgery. This was in this patient, pre-op anti-VEGF was given. This patient was already treated with PRP. Then there is a vitreous hemorrhage. You can take a chance by giving an anti-VEGF injection, especially if you see that it's an NVD and there is no significant peripheral traction. And coming to a few scenarios where you have associated corneal disease or cataract with PDR, what to do? So this was a case, the patient had Fuchs dystrophy in both eyes, had cortical cataract, little bit of posterior subcapsular. The fundus shows the PDR, and now you can see that this patient actually, I decided to take for VR surgery and plan for cataract and SOR later. This was a case of bilateral neovascular glaucoma patient, PDR, untreated. So patient initially received an anti-VEGF to regress the NBI before cataract, then did cataract surgery. And you can plan either cataract with PPV or cataract followed by PPV in these patients as a last resort. So this is a flow chart. If fundus view can be seen, then if PDR is quiet, you can plan for phaco surgery. If the disease is active, you can plan PRP plus anti-VEGF if you have planned an early cataract surgery. If PDR is active and still you have time, then wait for at least 3 months before cataract surgery. If the view is not there, get a B scan done and see whether it's vitreous hemorrhage or TRD. If there is not, then plan for a cataract with anti-VEGF, and you can plan PRP after the cataract surgery. Anti-VEGF will give you some time. And if there is associated VH or TRD, you can plan cataract with anti-VEGF first sitting and plan VR surgery in 1 week, or you can do it in single sitting. So to conclude, emphasis on the importance of systemic control. PRP is still the gold standard. A risk of VH and progression of PDR despite laser treatment can be there. So patient needs regular follow-up. Anti-VEGF can be used as an adjuvant. Vitrectomy can be considered in eyes with VH with worse vision or for early visual rehabilitation. Treat PDR first wherever possible when associated with other ocular diseases. Thank you.